Dr. Dhananjaya I Bhat, consultant neurosurgeon at Aster RV hospital. Today I will be talking about carpal tunnel syndrome. This is one of the most common entrapment neuropathies which people face in their day-to-day lives. It is characterized by severe pain, numbness and weakness in the fingers of the hand, especially the thumb, the index and the middle finger. It is commonly seen in women, middle-aged, people who are little obese, who have diabetes, hypertension, pregnant women, and sometimes in certain endocrine disorders like acromegaly and inflammatory conditions like rheumatoid arthritis. This problem occurs because there is a small nerve known as the median nerve which passes from the wrist into the hand. As it goes, it passes through a small tunnel which is surrounded by bone and some fibrous tissue known as carpal tunnel. So when this tunnel becomes narrow, either because of the swelling of these ligaments or some disorders of the bone, there is compression over this median nerve, and this results in pain and numbness in the fingers. Clinically, when we see, people typically tell that whenever they do work like wringing clothes, opening jars, significant writing or on the computer keyboards, they start developing tingling, numbness, paresthesias, as if some pin is pricking the fingers. And slowly as the disease worsens, they will start developing thinning of the muscles, especially the thumb muscles. The hands become thinner. There will be tremors in the hand, anything difficulty in holding objects, the pen difficulty in writing. When you hold an object, it will slip. These are the findings. And in the night, the pain will worsen. Many of these patients get up in the night because of severe pain. They have to leave their hand down, or there's something known as a flick sign where they have to flick their fingers, and that will give them some relief. So when a patient comes like this to our OPD, first a clinical examination, history, all these things we have a doubt, and we almost finalize it and come to know that it is carpal tunnel syndrome. Then how do we confirm? Confirmation is done through certain tests, the most important one being nerve conduction test. So in this we give small currents on the hand, on the forearm area, and we measure it in the finger area. So by knowing the volume, the speed in which the current is coming, we can zero it at the wrist, that the problem is at the wrist. And then carpal tunnel disease is confirmed. Other tests what we do is in certain cases when we still have strong doubt, but ENMG or the nerve conduction studies are plus minus, is that we may ask for an MRI or an ultrasound. In these two we can visually see the nerve, whether the nerve is thickened, compressed, or whether there are some tumors over there, and that will help us. So once diagnosis is done, the next comes the management. Now management can be divided into two. One is medical management, other one is surgical management. In the initial phases, we consider medical management where we give rest. We put a splint in the hand and the hand is given rest. With that, many of them have some relief. Along with that, certain medications like amitriptyline, then pregabalin, gabapentin. There are many medications which we try. With that, most of them have relief, and then slowly with that we start physiotherapy exercises and bring them back to normal. But as the disease progresses, then medical management may not be efficient. Some people advocate giving a small dose of steroids at the wrist level, and that has got certain temporary benefits for around 3 months, and then again the symptoms may recur. But once the disease has progressed, they have weakness, there is wasting or thinning of the muscles, the next option will be surgery. Surgery for carpal tunnel is relatively simple and safe. It is hardly a half an hour procedure where we do it under local anesthesia. A small injection is given at the wrist. So injection, a small prick will be felt. After that there will be no pain. The incision is around 1.5 centimeters in the region of the wrist. Following this, we open it, and the flexor retinaculum, which is the fibrous tissue which is pressing over the nerve, is incised and cut. That relieves the median nerve. And almost immediately after the surgery itself, most of the patients report improvement in their numbness and tingling sensations. See, what is important to realize in these surgeries is that once the muscle is wasted, once full weakness has developed, then there is no way that we can return the strength. So surgery needs to be done early, immediately. As soon as we realize that medical management is not working, the disease is progressing, the compression is increasing, surgery has to be done immediately. That time the results are very good. So following this surgery is done as daycare procedure, and by morning if you finish, by evening person can go home. Next day onwards needs to clean the wound, have bath and normal. Just some rest needs to be given so that the wound heals. By a week or in 10 days, the sutures are removed, and slowly with physiotherapy, you can get back to your routine activities. Here at Aster RV, we have a team of neurologists, neurosurgeons, and electrophysiologists. So immediately, as soon as the person comes with a doubt of carpal tunnel, our neurologists evaluate the patient. We get our electrophysiology done with the state-of-the-art equipments, and then if surgery is required, it is handed over to the neurosurgery department, where we also have a team of neurosurgeons as well as our anesthetists who can manage these cases very effectively and safely.